Okay, welcome everybody. If we could get everybody to sit down, we'll get started here. Thank you everybody for being here today on November the 8th for our exciting telehealth session. And I'm Frank Chalet from the Parkinson's Resource Center of Spokane here. And I'd like to just do a couple upfront announcements as per usual. And I think you guys will really enjoy the treat we have in store for you today with Dr. Britt. First of all, it goes without saying we want to thank our sponsors, Albertsons, for our corporate support, Northwest Parkinson's Foundation, our friends in Seattle, our host, St. Luke's Rehab Center here, Tammy and the staff at INHS for certainly putting this production on and making this happen. Our Spokane audience and, of course, all of you in the remote sites, welcome and thank you for being here today. Our donors, of course, for bottom line for making this happen. So thank you to all of you here today and many of those out there that have provided financial support to help us bring telehealth to each and every one of you. And last but not least, our PRC staff and the board of directors for their support in providing the services to the community. So, as always, as we get rolling here for today's topic, let's hold the questions till the end, and we'll do the roll call at that time at the various sites, including Spokane here. Remote sites, just a reminder, please do mute your microphones until it comes to the Q&A time. We appreciate that. And at that time, we will entertain questions when Dr. Britt is finished here. So without further ado, I'd like to introduce today's speaker, Dr. Bill Britt. He's a local neurologist in town here. We're very fortunate to have him with us. He specializes in movement disorders, especially an important one for us today, Parkinson's disease. And his topic today is going to be characteristics of dementia in the Parkinsonian syndrome. So without further ado, please welcome Dr. Bill Britt.
I think I have everything organized here. I'll try to remember to speak up into the microphone. If I get too soft, just wave at me. I was thinking about this topic a little bit driving over here. Giving a presentation like this gives me the opportunity to review some recent literature and to organize my thoughts. And so what I really get out of this is what I've learned in preparing the presentation. Also, to give a presentation to a group like this that has had extensive education in the area of Parkinson's disease, and to have it meaningful, I have to give a, in terms of the clinical information and science, a pretty high level of information to the group. So that is also an encouraging thing for me. I'm going to go through a presentation, and then I have a little surprise at the end, which I think will, at least I hope, will enhance the learning experience and will, pretty sure, provide a little novelty. Parkinsonian syndromes refer to a variety of neurological disorders that share a disturbance of movement that is typical of Parkinson's disease, and it's called Parkinsonism, and that is the altered tone of muscles in the body, the tendency for slowness of movement, the occurrence in many of the conditions and many of the patients affected of tremor, and of the eventual development of disorders of gait and balance. So when we refer to Parkinsonian syndromes, this refers to a number of neurological disorders that have that common feature. Now, these can be characterized in many different ways. And the way I chose to organize the presentation today was to break the categories of Parkinsonian syndromes into their most characteristic pathological findings when the brain tissue is studied after death. And that would allow us to break these syndromes into three areas. One would be the synucleinopathies. That word just flows nicely. I love that. When you add the suffix opathy to a word in medicine, that means something wrong with it. Okay? A synucleinopathy is something wrong with this protein called alpha-synuclein. A tauopathy is something wrong with this protein called tau. And then there are a few other disorders that do not have abnormal accumulations of proteins in the brain. Now, synuclein is a protein that occurs in nerve cells that exists in the nerve cell right at the terminal of the axon. So there's a nerve cell body and then a long axon, and electric or ionic current actually flows along the axon, originating at the cell body until it gets to the terminal of the nerve. And when it reaches the terminal of the nerve, it triggers the release of packets of chemicals from the end of that nerve, which interact with receptors for those chemicals on adjacent nerve cells. Now, synuclein functions at the terminal of the nerve and in some way participates in the release of packets of chemicals that are synthesized in the nerve cells, transported to the nerve cell terminal, and released when the membrane is depolarized by ionic current. Now, the precise function of synuclein in facilitating this release of chemicals is not yet known, and that's an area of active research. But I wanted to remind you that the very first demonstration of a distinct genetic disorder in a kindred, large family with many members affected with typical Parkinson's disease, typical symptom-wise, typical on autopsy examination of the brain, found the disturbance in the gene that produces alpha-synuclein. And it turns out that that disturbance this was in the Corturzi family, which was studied through the 1990s. That family has members in Greece and southern Italy. And they were found to have a single point mutation in the gene for alpha-synuclein. Now, a single point mutation means that when that gene is read by the machinery within the cell that produces a protein from it, one amino acid in the whole sequence of that protein is different from normal. In other words, the single point mutation allows for the insertion of, or the exchange of one amino acid for another, and changes the structure of synuclein slightly. And what was learned after that discovery had a great deal of implication about the cause of cell death in Parkinson's disease, which is that synuclein accumulates with a few other proteins in nerve cells in Parkinson's disease, and is the main ingredient of one of the characteristic pathological findings, which is called the Lewy body. Synuclein is there attached to a protein called ubiquitin in very high concentration. Now, when a cell in the body wants to get rid of a protein, it attaches ubiquitin to that protein, and ubiquitin guides it into the pathway for degradation of the protein. So these proteins that are produced in the nerve cells are continuously produced and destroyed. Well, the gene defect in the Corturzi family in the alpha-synuclein resulted in aberrant alpha-synuclein showed us that a key characteristic of the damage to nerve cells in Parkinson's disease is the lack of ability or the loss of ability to properly turn over proteins within these nerve cells. So that synuclein accumulated abnormally, and that led in some way to the processes that led to nerve cell death. Now, whether synuclein, when it accumulates, is toxic itself, whether it simply overwhelms the machinery in these cells for producing and degrading proteins, so on, those things aren't yet known. But there's a group of disorders within the Parkinsonian syndromes in which the accumulation of alpha-synuclein occurs, and they're called the synucleinopathies. Now, tauopathies are a different group of disorders. Tau protein is a structural protein in the axons of nerve cells. So there's a cell body, the long axon, ionic current flows along, it gets to the terminus, and when that end of the nerve cell depolarizes, chemicals are released, neurotransmitters are released, and so on. Tau protein functions as one of the skeletal proteins in axons, so that when nerve cells degenerate and die, there is the release of excessive amounts of tau into the tissues, and it's not entirely degraded. And so the tauopathies are conditions in which the pathological study of the brain after death shows abnormal accumulations of tau protein. Scientific enough for you yet? Good. Okay. Now, the synucleinopathies. Motor referring to movement, and eventually, for most people, cognitive disturbance. Cognitive is the higher aspects of brain functioning, language, vision, processing, spatial orientation, judgment, reasoning, memory, calculations, so on. Motor and cognitive disorders due to neuronal, that's nerve cell degeneration. In other words, these nerve cells are not damaged by stroke or inflammation or tumors, whatever. These nerve cells are sick because of something wrong within them, and they degenerate and die. So synucleinopathies, motor and cognitive disorders caused by nerve cell degeneration, and the tissue shows inclusion bodies. Inclusion bodies refers to abnormal microscopic structures that are within cells. And of course, in the synucleinopathies, these inclusion bodies contain alpha-synuclein. And with the synucleinopathies that cause dementia, we have Parkinson's disease with dementia, dementia with Lewy bodies, and Lewy bodies are intracellular, within cell, and actually within nerve cells, inclusion bodies. And then a condition called multiple system atrophy, in which the intracellular synuclein containing structures are within, not within nerve cells, but within other supporting cells within the tissues of the brain. Now, I'd like to pause for a second and discuss the term dementia and how that's used in clinical practice. The word in its most elemental form would mean a decline of mental function. And of course, we all have a decline of mental function with aging, but actually that is not dementia, that is normal age-related change in the nervous system. Dementia, as it's used in clinical practice and is defined in that's called the DSM, Diagnostic and Statistical Manual, refers to a condition in which there is a disturbance of memory and of a disturbance of mental functions or cognitive functions sufficient to require sufficient that individuals require assistance with activities of daily living. That's eating, dressing, grooming, bathing, using the toilet. So this indicates a fairly severe disturbance in cognitive function. this will often begin, I love the term, often begin with a disturbance of instrumental activities of daily living. And this is starting the car, using the TV remote, using the appliances in the house and the power tools and so on. So they're both instrumental activities of daily living and then the personal activities of daily living. So that's what is meant by dementia. Tauopathies, motor and cognitive disorders due to nerve cell degeneration and the accumulation of tau protein, which forms actually fibrillary structures. These are long, thin structures that come out of solution in the tissues and look kind of like a starburst appearance under the microscope. And those conditions are progressive supranuclear palsy, corticobasal degeneration, and then people with Alzheimer's disease have neurofibrillary tau protein accumulations, as well as another key abnormality called neuritic plaques. And the main protein constituent that drives the formation of these plaques is called amyloid. Other conditions, vascular Parkinsonism. This is people who develop Parkinsonism because of multiple strokes. Condition called normal pressure hydrocephalus, in which there's an impairment of the reabsorption of spinal fluid that produces some abnormalities in the brain. And then there are some individuals with Alzheimer's disease who get prominent extrapyramidal signs, and extrapyramidal is another word for Parkinsonism. Now, motor signs develop in these disorders, and of course when it's typical Parkinsonism, there's an asymmetry. Usually one side of the body is more severely affected than the other, particularly by tremor. Also, there is increased tone in the limbs and neck muscles, slowness of the speed of movement and the speed of thinking, and eventually some disturbance of gait and balance. And when typical Parkinsonism is the presenting motor sign, it is usually, in a patient with dementia, it is usually due to Parkinson's disease with dementia, although some cases of dementia with Lewy bodies will show very typical Parkinsonism before the onset of dementia. Now, atypical Parkinsonism refers to features of Parkinson's disease, but in which there is seldom tremor. There's not an asymmetry, that is, the limbs and functions in terms of tone and dexterity, so on, are quite similar on the two sides. The rigidity affects the truncal muscles much more so than the limb muscles. And the patients with dementia whose motor signs are atypical Parkinsonism usually have multiple system atrophy, progressive supranuclear palsy, we'll call that PSP, corticobasal degeneration, although some patients with dementia with Lewy bodies will present with atypical Parkinsonism as well. Now, if a presenting motor sign is ataxia, and this is a severe disturbance of coordination or balance without other signs of Parkinsonism, that is a variant of multiple system atrophy. And when the presenting motor disturbance is dystonia, abnormal movements, postures, tension that affects a discrete area of the body, or myoclonus, and these are sudden jerks, that indicates that the dementia is usually due to this condition called corticobasal degeneration. And motor signs present in people with Parkinson's disease, progressive supranuclear palsy, and multiple system atrophy initially, whereas cognitive signs are usually the presenting symptom in people with dementia with Lewy bodies or corticobasal degeneration. Now, the cognitive dysfunction that occurs in the Parkinsonian syndromes is usually quite different from the kind of cognitive disturbance that is the main feature of Alzheimer's disease, because people with Alzheimer's disease develop memory disorder, particularly affecting short-term recall, for years before memory function becomes severely impaired and aspects of daily living, activities of daily living are impacted. And this memory disorder occurs in 90% of patients with Alzheimer's disease before dementia develops. Whereas in the Parkinsonian syndromes, a condition referred to as subcortical dementia, it characterizes the cognitive disturbance much better. Now, the cortex of the brain is the highest surface. This is where majority of nerve cell bodies are located that participate in the higher functions of the brain. And people with Alzheimer's disease have degeneration of nerve cells in the cortex of the brain. So they have a cortical dementia, if you will. But people with cognitive dysfunction due to the Parkinsonian syndromes usually have relatively preserved structure within the cortex of the brain for a long time, and certainly when dementia begins, but have deeper structures affected as they are affected in Parkinson's disease and causing the disturbance of movement. So it's called a subcortical or below or beneath the cortex kind of dementia. And its features are quite different than purely a memory disorder with a slow speed of cognitive processing. The speed at which the mind works it slows considerably, and that is usually accompanied by significant disturbances of attention, of maintaining attention and concentration. Another key feature of subcortical dementia is called executive dysfunction, and that refers to the whole integrative process of planning, organizing, sequencing, multitasking that are required at work usually and in normal life. And then visual spatial disorganization, the ability to be in the store, in the giant warehouse store now, which is where we seem to shop, and knowing where the exit is and where the cash register is, and then walking out and finding your car and being able to use the cues that you have for visually to find your way around. That aspect becomes very impaired. We have some, now I would call them screening tests. That is, someone comes to my office and says my memory is not working right. And so I examine them physically and I take a medical history, and I also do an additional test that screens them. Do they have something more than simply age-related memory decline? And a good test for that is called the mini mental state examination. And we use that in the detection of people with Alzheimer's disease and in following the response to medicine and over time the changes of deterioration in their mental performance. And this is a good screen for people with Alzheimer's disease and for patients with severe cases of dementia with Lewy bodies. But it's a poorer screen for people with Parkinsonian syndromes who have cognitive dysfunction because it is not very sensitive to milder impairments, and it is not sensitive at all to executive dysfunction. So for the patients with Parkinsonian syndromes, in which we ask the question, is there cognitive impairment, we use a couple of other tests. At present, I'm using the Montreal Cognitive Assessment. There's another one that's called an extended MMSE, and both of these are sensitive to executive dysfunction. When I see someone with a Parkinsonian syndrome who's beginning to have cognitive deterioration, it is usually, they usually don't come and complain that, you know, my brain works slowly and I can't pay attention very well and so on. And they don't say I, you know, walk out of the grocery store and I can't find my car, but they talk about things that pertain to executive dysfunction. And so we do have some screening tools that can indicate to us with a high probability whether disturbance of executive function that's more severe than that associated with normal aging is present. Now, neuropsychiatric symptoms occur very commonly in the Parkinsonian syndromes that cause dementia. And the two most common symptoms are depression, that's a deterioration of mood with a very morbid mood outlook. I'm worthless, nothing good can happen, and anxiety. Anxiety is very common in the Parkinsonian syndromes with dementia. Anxiety is this poorly focused feeling of unease and restlessness. Also common in this group of patients is apathy. And that's the term for the people who have no interest, no ambition or drive to do things that they used to find enjoyable, no drive to interact socially with family members. The spouse says, all he does is sit there on the sofa every day. He doesn't even turn the TV on. That is severe apathy, and that's also a common symptom and actually very hard to treat in this group of patients. Then sleep disturbances, excessive daytime sleepiness, chaotic sleep pattern, frequent nocturnal arousing or frequent arousals during the night, so frequent nocturnal arousals, and then a condition called REM sleep behavioral disorder that I'll describe further in a minute. And then in terms of neuropsychiatric disturbances, patients with dementia with Lewy bodies or Parkinson's disease with dementia characteristically have hallucinations. They're predominantly visual. They're usually animated, people, animals. They're often in the home or just outside the home. And psychosis, this is disturbed thinking, a real impairment in reality testing. And so these people will, believe that, the husband is having affairs all the time, and every time he goes out to do anything, he's gone to see the woman. And so that would be a common example in my practice. Now, the specific disorder of Parkinson's disease with dementia, and I was surprised at the statistic, but this comes from data collected in the last 5 years of the past decade. So the prevalence, that's the number of, or the percentage of patients within a given population that is affected by a condition. So, for example, the prevalence of hypertension in the United States is about 50%. Half our population is hypertensive by current American Heart Association definition. Well, the prevalence of dementia in people with Parkinson's disease is said to be 30% now. So 30% of our patients with Parkinson's disease meet diagnostic criteria for dementia. I was surprised at that, and I think that number has increased over the years simply because the general health care is so much better. People are living with Parkinson's disease and other chronic illnesses to a much later age. Now, the lifetime risk, if you have Parkinson's disease, what is your lifetime risk of developing dementia? The number is given at 80%. So this underscores the new comprehension of Parkinson's disease as being far more than a disturbance of movement, than stiffness and tremor. That it has a number of associated features that imply that there's damage in other areas of the nervous system. It, for example, often affects blood pressure, bladder function. It often affects individuals' mental functions, stuff. So this is a disturbance in the brain that affects many systems and not just the motor systems that are the initial manifestation. You're at greater risk of developing dementia if you have Parkinson's disease, if you live to an old age, have an older age of onset of symptoms, have a longer duration of disease. That is, more commonly see people developing dementia after 15, 20, 25 years with Parkinson's disease. If you do not have tremor, if you have this condition called mild cognitive impairment, that's the memory disorder that occurs in people with Alzheimer's disease and precedes the development of dementia in those patients. And interestingly, if you have depression as a feature of the neurological disorder, about 1/3 of patients with Parkinson's disease will be treated for at least one episode of severe depression. And that appears, the biochemical disturbance in the brain that causes depression in these individuals somehow also increases the risk for development of dementia. Now, the pathology of Parkinson's disease with dementia, there is one of these inclusion bodies within remaining nerve cells called the Lewy body that's found both in subcortical structures commonly affected by Parkinson's disease and through the cortex, or the higher surfaces of the brain. Now, one of the prominent neurotransmitters in the brain is called acetylcholine. And their memory function is not discretely localized within the brain. For example, my speech center is here. If I have a stroke in the back part of my left frontal lobe, I lose my ability to express myself. I may be able to formulate thoughts, I may be able to do many things physically, but my ability to say words, make sentences that make sense, write in words and sentences that make sense, would be lost. The back right side of my brain processes visual information from my left visual space in each eye. So if I have a stroke there, I lose vision off to the left side in each eye. So those are very discretely localized functions within the brain. But memory function is not discretely localized. It is spread throughout the brain. So when you get the whiff of the bread baking and you think of your grandmother's kitchen and seeing your grandmother slaving away in the hot kitchen, and remember the warm feelings that you had for her, and so on. There's an elaborate network within the brain that functions, that provides our memory function. And that network uses the chemical acetylcholine to communicate between cells. Now, the reason people with Alzheimer's disease are losing their recent memory function is that acetylcholine producing nerve cells within the brain are dying out prematurely. And it will especially affect structures in the deep temporal lobes called the hippocampus on each side, which is critical in memory retrieval and storage. And so the short-term memory deficit in people with Alzheimer's disease is due to loss of acetylcholine producing nerve cells at an early phase of that process that are involved in memory function. But the deficiency of acetylcholine in the cortex of the brain of people who have had Parkinson's disease with dementia is much greater than that seen in Alzheimer's disease. And that accounts for a considerable component of the aspects of cognitive disturbances. Now, also, people with Parkinson's disease with dementia, 1/2 of them will have an accumulation of neuritic plaques and neurofibrillary tangles that will qualify them pathologically for the diagnosis of Alzheimer's disease also. Now, that's much higher than age-related, pathology, subjects who do not have Parkinson's disease. So another concept about Parkinson's disease is that it increases the risk for development of Alzheimer's disease in the individual. Now, associated features, in addition to the neuropsychiatric symptoms, depression being very common, impairment of working memory. That is, I look up the phone number in the phone book, and I put the phone book aside and go to the phone, and I'm supposed to be able to recall the 7-digit number in my brain, but by the time I get there, it's gone. That is working memory, that very short-term things in immediate memory function. Excessive daytime sleepiness is a very frequent feature, and it's due to the impairment of sleep and waking regulation in people with Parkinson's disease with dementia. And then this group of patients also is prone to impulse control disorders. This is what we hear about that is aggravated by dopamine agonist treatment, one of the groups of medicines that's used for treatment of Parkinson's symptoms. But these individuals may experience compulsions with gambling, sexual eating, shopping, or hoarding behaviors. I was channel surfing and I came across the title of a show called Hoarding on it. I didn't actually stop to watch it, but I'm going to have to turn that on and see what that shows. Now, dementia with Lewy bodies is described as a condition in which there's progressive cognitive decline beginning before or within 1 year of the onset of Parkinsonian motor signs or of Parkinsonism. And it turns out that dementia with Lewy bodies is the cause of dementia in 20% of the people in the population who are affected. Alzheimer's disease apparently is the cause in about 60% of people with dementia. So this is the second most common cause of dementia in our society. There's a pathological overlap with Alzheimer's disease, although the patients with dementia with Lewy bodies will have fewer neurofibrillary tangles, these abnormal accumulations of tau protein. And in areas where there are neurofibrillary tangles in the brains of people with Alzheimer's disease, that's where you find the greatest degree of nerve cell loss. And so because there are fewer neurofibrillary tangles, there's less nerve cell loss in dementia with Lewy bodies in the vicinity of those tangles. There is also less involvement of the hippocampus in each temporal lobe, so that memory disorder is not often the presenting complaint and may not even be a prominent feature of the dementia. But there's more involvement in another area of the brain called the cingulate region. The cingulate gyrus, the hemispheres of the brain are divided right here. Well, if you open it up, just inside there on each hemisphere is the cingulate gyrus on each side. So there's the anterior and posterior part of the cingulate gyrus. And there's much more involvement of this cingulate region with Lewy bodies and Alzheimer's disease pathology than is seen in Alzheimer's disease. There are also some imaging characteristics of dementia with Lewy bodies that can tell us with a high degree of accuracy that the condition the patient is experiencing is dementia with Lewy bodies, and that includes PET scanning of the brain. PET is positron emission tomography, and what it refers to is that the individuals are given an injection of radioactive glucose, which is taken up in areas where metabolism is very high in the body. Well, the brain is entirely dependent on glucose for its metabolism. And so about a third of the glucose or sugar that our body makes is actually used by the brain to support its metabolism. Well, when the PET scanning is done, that is, this radioactive glucose is injected, then you can get a pattern of the uptake and the degree of metabolic activity throughout the brain. And in patients with dementia with Lewy bodies, the occipital lobes, where vision is processed, show a reduction of metabolism. That can be demonstrated, but less. SPECT imaging is a nuclear medicine technique that can be demonstrated in some cases when it's advanced, but the PET scanning is more sensitive to milder disturbances in metabolism than the SPECT scanning is. Also, there's a research technique that looks at the presence of the terminals of dopamine-producing nerve cells in the subcortical areas of the brain. There you can bind a dopamine transporter. That's actually a protein at the terminal of dopamine-producing nerve cells that reuptakes dopamine after it's been released. And if those nerve cells have died out, there's less dopamine transporter protein there, and that can also be identified, although it's not yet available to us for routine clinical use. And neither of these imaging findings is present in Alzheimer's disease. Now, the symptoms of dementia with Lewy bodies are very consistent. And these individuals experience a considerable fluctuation of their mental functions, their cognitive functions, and even of consciousness. So these individuals will often have long periods of sleepiness or sleep during the day, alternating with other periods and entire days of complete alertness. Also, one day's good and one day's not. They have visual hallucinations. Hallucinations in other sensory systems, touch and auditory hallucinations occur on occasion, but visual hallucinations are very common. Now, a hallucination is the visual perception of something that is not there. And illusion is the distorted perception of something there. So the hat rack looks with the coat hanging on it, looks like the man standing there. Or heard that, and the other one I heard not long ago was the bowl with pine cones in it had a man's head sitting on top of it. Those are visual illusions, also common in this condition. Hallucinations, things absolutely not there. People outdoor at night running around in the neighborhood, coming up to the house, kids running around in the basement, people coming into the bedroom through the walls, those kind of things. REM sleep behavioral disorder is very common in this group. REM sleep is that phase of sleep during which we dream. And when we dream, there is 10 minutes? Okay, we'll move on quickly. And when we dream, there is a suppression of the outflow in movement controlling pathways from the brain into the spinal cord. So that when we're dreaming, we actually have paralysis in the body except for our diaphragm, which breathes for us, and the muscles that move the eyes. REM stands for rapid eye movement. And that's the dream phase of sleep. But in people with dementia with Lewy bodies, that paralysis does not occur, or it does not occur consistently, so that they act out on the dreams, hit, flail, kick, shout. I hear them fighting World War II every night, stuff like that. Some of these patients actually present to emergency departments with injuries, having hit the nightstand or jumped up and was kicking the soccer ball and kicked the door frame. And then these patients are very sensitive to a class of medicines called neuroleptics. The neuroleptics will diminish or eliminate hallucinations, but may cause severe disturbance of consciousness, unconsciousness for days, can't take the medicines, get very rigid, and so on, and actually may result in death in these individuals. So those are involved. Now, I'll move quickly. Dementia with Lewy bodies causes executive dysfunction and visual spatial disturbances. Remember, the visual processing area of the brain is quite affected, and there's disturbance of attention, more prominent psychiatric features. And interestingly, because of the greater deficiency of acetylcholine in the brain, produces a better response to the medications given to people with dementia, like Aricept, Exelon, and Razidine or galantamine, than occurs in people with Alzheimer's disease. And these medicines also diminish hallucinations. Now, the medical treatment of dementia in people with Parkinson's disease and dementia with Lewy bodies includes this class of medicines, acetylcholinesterase inhibitors, meaning it inhibits the enzyme that removes acetylcholine, so more of it hangs around. Exelon is FDA approved in people with Parkinson's disease and is our only approved therapy, although the trial that was done showed only a very mild benefit. The others can be beneficial. If we have to use antipsychotic medications, we avoid the neuroleptics and use ones called atypical antipsychotics. They do not block dopamine receptors, and they do not cause disturbed consciousness in this group of patients. Namenda, another Alzheimer's drug, may have slight benefit. That's unpredictable and not consistent. We try to avoid medicines that impair acetylcholine functions, like medicines that are used for bladder control. Antidepressants, the group of medicines called SSRIs, this is Prozac, sertraline, citalopram, Lexapro, and so on, that group. They're anti-anxiety agents for use. And for people with REM sleep behavioral disorder, bedtime dose of clonazepam, which is an old benzodiazepine. That's a group of medicines of Valium, Librium, Ativan, Xanax stuff. Bedtime dose of clonazepam is very effective. Multiple system atrophy can look like Parkinsonism initially, or produce ataxia from damage in the cerebellum initially. And these patients develop other systems in the nervous system, become quite impaired. So they develop also spasticity in the limbs, fall in blood pressure, poor blood pressure control when they're standing. But dementia is an infrequent and late complication, and and depression a very prominent feature. PSP causes impairment of eye movements, especially looking down, no tremor, severe truncal rigidity, swallowing and talking difficulties, and problems with balance and falls within 1 year of symptom onset. There may be a late finding on MRI that will absolutely confirm that diagnosis. And the cognitive signs: slow speed of mental processing, severe executive dysfunction, but memory impairment usually mild. And pseudobulbar affect is the emotional appearance of, is the physical appearance of an emotion without the individual expressing the emotion. So if I just all of a sudden started crying, but someone asked me, well, what are you upset about? I say, I'm not sad at all. I'm not upset. I'm just crying. That is called pseudobulbar affect. And medical treatments are quite limited, but mainly for the neuropsychiatric symptoms and pseudobulbar affect. Cortical basal degeneration can mimic PSP, and the diagnosis has to be confirmed pathologically. They have a variety of severe neurological disturbances. I'm going to go on quickly, but the Parkinsonism in these patients may respond to L-DOPA. Clonazepam may help these neurological symptoms, and some patients get Botox injections when they have severe dystonia in an area of the body. Vascular Parkinsonism, multiple small strokes, usually affects gait and leg function. So it was originally referred to as lower half or lower body Parkinsonism, and these patients, although they have strokes in areas of the brain where there's typical neuronal degeneration in Parkinson's disease, they may also respond to L-DOPA therapy. Normal pressure hydrocephalus, large ventricles, the sacs in the brain where the spinal fluid is formed. So when we have atypical Parkinsonism and we want to do a brain image to see the size of the ventricles in the brain, and when they're quite enlarged, shunting the spinal fluid by placement of a small catheter and draining it into the abdominal cavity will improve gait, but it does not, it may stabilize bladder function and dementia, but it doesn't tend to improve those things. Now I'm going to stop there. Do I have about 5 more minutes for a little novel item? Okay. I am going to read a short story that's called Company. The story was, I wrote this about a year ago. It is not published, so you should think of this as work in progress. The old man walked on the edge of the recently oiled road, each stride scuffing the gravel. He turned onto the weedy pebble path to his home. The grating sound continued until he reached the wooden steps. There he shifted the grocery sack to his left arm and pulled the key ring out of a pocket on his quilted flannel jacket. Something dark darted in the periphery of his vision. Holding the keys in his right hand, he ascended the steps, clutching awkwardly to the railing. He stood on the platform entry, fumbling clumsily with the keys. The transparent hand of a very tall man standing beside him touched the door. When the lock clicked, the tall man pushed gently on the door, which swung open. The old man went inside, set the sack down, and turned to welcome his visitor. No one was standing behind him, and when he returned to the doorway, no one was there. He took the key out of the lock and closed the door. Then he went to the kitchen and ignited a gas burner on the cooktop. While the chili was warming, he reached back to the electric can opener, slid the tin top of the emptied chili can off the magnet, and tossed it into the garbage. He stirred the chili occasionally until it bubbled. Waiting for the chili to cool, he poured a glass of milk from the carton he had just bought at the grocery store bait shop. He scooped half the chili onto a plate and took it into the lounge adjacent to the kitchen dining area. He set the plate on the coffee table in front of the sofa and carefully placed a tablespoon beside it. He thought, that ought to keep her quiet. Then he sat at the dinette and ate the remainder of the chili directly from the pot. After the late lunch, he took a medicine bottle off the kitchen counter, removed the top with difficulty, and poured out 4 pills onto a saucer. He took one with the last sip of milk in the glass, picked up the saucer, and carried it to the dinette. His hands shook as he walked, and 2 of the pills fell onto the faded linoleum. Then he saw her again, the diaphanous woman sitting expressionless in his usual place on the sofa. She was staring at the television across the room, her chest moving as she breathed. "What are you doing here?" he called. She did not answer, move, or look his way. He stepped to the edge of the lounge and looked where her gaze was fixed. The television was off, and no one was there. When he looked back to the sofa, the woman was gone. He saw the crease and indentation in the cushion where she had been sitting. Leaving the bathroom that evening, he slid the pocket door closed. Light from a small fixture installed in the outlet at the top of the mirror shone beneath the door into the short hallway. When he reached his bed, he pulled the covers down, sat on the edge, and fell back. He strained to raise his legs onto the mattress and struggled onto his side. He switched the lamp on the bedside table off, rolled onto his back, and lay still, listening. It wasn't long before he heard them moving in the other room, their feet sliding across the floor. Dancing? Don't they know I'm here trying to sleep? He felt movement on his right thigh, which was covered with a sheet. He took his hand off that leg and placed it on the bed beside him. The hand quit shaking, and the dancing stopped. During the night, he needed to urinate. He got his feet off the edge of the bed, tossed the top sheet aside, and sat up. He was dizzy when he stood, so he leaned against the wall until it passed. He edged around the bed, hoping the filmy tall man wouldn't be standing in the hallway pointing the way again. When he slid the bathroom door open, light flooded the area. Ha! I'm alone. The next morning, he was seated at the dinette having toast and coffee when the telephone rang. He shuffled to the kitchen counter, picked up the handset, and said, "Hello?" "Hi, Dad, it's Marcy." "Hi, honey," he said warmly. "How are you doing today?" she asked. "Well, my hands are shaking a lot," he answered. "Did you take your Cinemet this morning?" she asked. "No, I'm eating breakfast now." "Dad, you're supposed to take it a half an hour before you eat, before every meal," she admonished. "That's right," he acknowledged. "How are you getting along?" she asked. With no hint of emotion, he said, "I can't get my company to leave." "Are the people back again?" she asked. "Yeah, 2 of them. I set some traps. They've been eating my food. There's a plate of chili on the coffee table. They're taking my medicine, too. Yesterday I set out 3 Cinemets, and only one's there this morning." "Dad, I miss a day of work every time you have an appointment for these Parkinson's problems. When we went to see Dr. Krause last time, you told him you didn't see the people anymore," she said. "Well, they never left," he admitted. Marcy thought to herself, "I can't keep going out to that grungy fishing camp where he's determined to stay, bring him in to the doctor, then take him way back out there. She took a deep breath, forced herself to quiet her emotions, and said, "You've got medicine for that. Are you taking the Seroquel?" "That's the peach pill? I'm taking one every morning and 3 at night," he replied. "That's right," Marcy said. "Why didn't you tell the doctor about the people when you were there?" "They didn't want me to," he said. "Oh, Daddy," Marcy exclaimed. He saw the gossamer woman standing beside him. She raised an index finger to her lips and made a shushing gesture. Then she pointed at the telephone base. He heard Marcy start, "You can't keep doing this. I'm going to call the doc," before her voice disappeared when he set the receiver back on the cradle. The woman turned and walked into the lounge. He didn't answer the phone when it rang again, following the woman to the sofa instead. He sat down next to her, she statuesque, his hands and chin trembling. He knew she was looking at the blank television screen with him. "It'll come on in a minute," he assured her. "Would you like some coffee?" Okay. Are we getting questions?
Yeah, we'll do Q&A here in a second. Well, thank you, Dr. Britt. That was very, very interesting, and that short story shows that you have multiple talents beyond just being an excellent physician. Okay, this phase is our opportunity for Q&A from our remote sites as well as our team here in Spokane. And if the remote sites, if you guys would all turn your mics on now so we can hear you, that would be fantastic. So we've got a lot, which is good news. We've got 18 sites, including Spokane, with us today, so there's a lot of people. But I'm going to kind of jump back and forth, so it'll give everybody a chance, if you have a question, hopefully to ask a question, so bear with us. So I'm going to start at the top and then go a little bit back and forth. So first, Anchorage, Alaska. Folks, do you have a question for Dr. Britt?
Yes.
Okay.
Is there any medication that is extremely helpful in this case? In the case of dementia with Parkinson's?
Yes. The acetylcholinesterase inhibitors, those are the medicines that were developed for treatment of Alzheimer's disease in an early to moderately advanced phase, do aid the cognitive function and diminish hallucinations. And then when hallucinations are severe and disruptive, we use Seroquel now. The chemical name is quetiapine, as it diminishes hallucinations without blocking dopamine receptors in the brain, and so that it does not cause sedation in these patients or worsen the Parkinsonism.
Thanks. Thank you. Any further questions, Anchorage?
No.
Okay, let's go to Walla Walla. Providence St. Mary's. Folks, any questions?
Yes, earlier he talked about something that affected blood pressure. I wondered how it affected it. Did it produce high blood pressure or low?
Some of these disorders is for blood pressure regulation to be impaired, so that when one stands, the blood pressure falls abnormally low, which increases dizziness, imbalance, and risk for faints and fall. Some of those patients will also develop what's called supine hypertension, meaning when they lie down flat and the head and heart are at the same level, their blood pressure becomes abnormally high. And those patients are at risk for stroke caused by brain hemorrhage or bleeding in the tissues of the brain from the high blood pressure.
Walla Walla, any further question?
No, thank you.
Thank you. Our friends in Montana, any questions? Okay, moving on. Tenasket, North Valley Hospital, any questions, folks?
No questions, thank you.
Thank you very much. Okay, Clarkston, Tri-State Memorial.
No questions, thank you.
Thank you. Seattle, let's see, they're not. Oh, yeah, they are. Seattle, Virginia Mason Hospital. Any questions, folks? Okay. Coeur d'Alene, Kootenai Med Center.
Yes, I have one. You had said that Exelon had a mild benefit for treating dementia. Did you also say that anti-anxiety drugs should be avoided?
No, anxiety needs to be treated in patients with Parkinson's disease with dementia or dementia with Lewy bodies. Can be a severe and disabling symptom. And the safe ones to use are buspirone, that's the generic for a drug called Buspar, and the benzodiazepines in low doses.
Okay, so it was just the anti-chlorogenic drugs that you avoid?
Yeah, they're an older class of antipsychotic medications called neuroleptic medications. This was Thorazine, Haldol, Stelazine, drugs in that class would be very effective in treating hallucinations, suppressing hallucinations, but do cause severe sedation in patients with dementia with Lewy bodies. That's the class of drugs that we avoid.
All right, thank you.
Okay, thank you. Ritzville, East Adams Rural Hospital. Any questions? Okay, moving right along. Dayton General Hospital.
No questions here, but we enjoyed your program very much. Thank you.
Thank you so much. Okay, Pullman Regional Hospital, folks. Our Cougar friends down there.
No questions, I don't think.
We lost a good part of what you said. Was not transmitted.
I didn't catch that.
She said a lot of what was said was not transmitted.
Oh.
There's some technical problems at that site.
Yeah, well, we can, folks in Pullman, sorry about that. We can certainly, you can get one of the DVD, the discs. But call the Parkinson's Resource Center. We'll make sure you get that, and that way you should have all of it, okay?
Thank you.
Thank you. Sorry about that. Grangeville, Idaho. Any questions, folks? Okay. Pendleton, Public Library. Okay, thank you. Kennewick General Hospital, our friends in the Tri-Cities.
No questions, thank you.
All right, thank you. Othello Community Hospital. Okay, thank you, folks. Evergreen Healthcare in Kirkland. All right. Samaritan Healthcare in Moses Lake.
No questions.
All right, thank you for joining us. And Miles City, Montana. Folks, any questions out there in Miles City? Okay, and our very patient audience here in Spokane, folks, please feel free to raise your hand if you have any questions. Yes, ma'am.
First question.
I have to repeat these questions because I don't. Yeah, that'd be great.
First question.
Yeah, it should be on.
First question from Anchorage. They asked you about some medicines. I don't remember exactly what for them. I want to know how to spell them. Anyone else here? I thought it was for dementia. Yeah, okay.
For dementia.
And then somebody asked for anxiety.
Repeat the question.
Okay, good. For dementia, Parkinson's disease with dementia and dementia with Lewy bodies, Exelon is approved by the FDA for treatment. And that's available in patch form, and the tolerability is much better. So you want to try the Exelon patch if that comes up. Aricept is an older drug that's been used in the treatment of Alzheimer's disease for a long time. And galantamine is a generically available drug in the same class. The trade name was Razidine. Rimonil initially, and then Razidine, but it's available in generic. It's galantamine, Galantamine. And the anti-anxiety drugs that are used, buspirone, Buspirone, is very effective. And the benzodiazepine class of medicines, that's Ativan, Xanax, Valium, Librium, that group of medicines are available in generic form now. And they have an anti-anxiety effect, although they cause more sedation than buspirone. So they're plan B for treatment of anxiety.
Any more questions? Hold on, we'll wait for the mic.
They don't repeat the questions.
How do we decide if a tremor is due to Parkinson's disease? Okay. Well, the word tremor is used to refer to something that oscillates. So it shakes back and forth, as opposed to jerks, twitches, ticks, and so on, a whole other variety of spontaneous movements. The characteristics of a Parkinson tremor are that when it first starts, it usually begins on one side of the body and almost always in the arm and hand. And it is present at rest, meaning when the muscles are not being actively used. So when the individual is sitting with the hand in his lap, especially when walking, the rhythmic tremor occurs. It tends to be at a frequency measurement of 5 to 6 per second. And a rest tremor suppresses as soon as the limb is moved, so that an individual with shaking of the hand when it's sitting in his lap can just, extend the fingers or move the arm a bit, and that will transiently suppress the tremor. Also, a rest tremor can often be suppressed by focusing attention on it. So those are features of Parkinson's tremor that don't exist in any other tremor disorder. Other questions? Yes, sir.
In the field of those same drugs cause severe diarrhea. Is there anything you can do to take those same drugs without causing severe diarrhea?
Okay. Did everyone hear the question? A group of medicines like Aricept, Exelon, and galantamine cause diarrhea. What can be done to diminish that? The chemical system that these medicines are souping up in the brain, the acetylcholine system, exists in the intestine. And if you activate it in the intestine, you increase the intestinal muscle activity, intestinal motility, and you pass the contents on through with relatively less of the water within the contents being absorbed. So the stools become loose, or you get diarrhea when you activate that system. All of these drugs are used in a lower dose to start than the ultimate treatment dose, because the large majority of people will get tolerance to that effect in the intestine, and you will no longer get the activation of the system that results in diarrhea. For those patients who do at the therapeutic dose, despite going through the slow titration from the lower to the higher doses, we cut the dose back down, and usually you find a dose that is tolerable. But you may not get the optimal benefit in terms of treatment of the symptoms of dementia. I've had very poor success at trying to treat those cases with anti-medication.
Oh yeah, that was great. He was an intern.
Other things?
He was in the room, though.
Yes, ma'am.
Yeah. You can talk, right? Get your coat there, sweetie. Oh, you're getting it.
Kind of two-part, I guess. When are you typically doing screenings in your office? When are you seeing folks? And when do you recommend that maybe people get screened for dementias related to Parkinson's disease?
I don't have routine for assessment of cognitive function with any of the screening tools in people with Parkinson's disease and related disorders. So as one screens for other disturbances of movement in an early phase of the disease. But usually at the first sign of any symptoms, people complain of memory or losing their keys, or the spouse describes someone being repetitive or being unable to complete tasks, can't do the things in the shop, takes things apart, can't put them back together. As soon as there's a hint of cognitive disturbance, that's when I screen for those. Have we done it? Okay, good. Thank you.
Thank you, Dr. Britt. Outstanding. You taking the time to cover a pretty tough but very important subject for everybody. Before I close here, I'd also be remiss if we didn't thank one of our other supporters who's with us today, but certainly has supported us on many occasions. That's Teva Neuroscience. And so John Cahill in the back, give a round of applause to John. Okay, last couple things. Our next meeting is Monday, December 13th, and it's entitled Parkinson's Celebration. And what you're going to find is when you come in here, it's going to be a pretty good time. Our singing group, the Tremble Clefs, are going to be with us with their new director, Pam Baldwin. She's going to be directing a little singing time for us, which I think will be a pretty good time. And let me get my other sheet here. Walter Jakubowski is going to also, and he's our secretary for the PRC. Terry will talk about our Dance for Parkinson's group that were created by the Mark Morris Dance Group. So a lot of fun things to come next month, so if you can attend, we'd love to have you. So again, thank you everybody for your time and your support, and we'll look forward to seeing you next month.
I'll take this. He wanted to get a copy of the PowerPoint.
Okay, okay.
For the video.
Okay, thanks. Oh, and as you guys are walking out, you'll notice we've got the brochures for the PRC. It's an overview, kind of gives you basic information if you want something like that. And also the Tremble Clefs are selling mugs out there, which are helping support all their efforts if you're interested in one of their nice mugs out there, okay? Thanks, everybody. And Parky says thank you for supporting the PRC.